Top Med Talk. Well, hello, welcome to Top Med Talk. I'm Andy Cumpsty and I'm here with my co-host Joff Lacey, and we're packing in the podcast today on day 2 of the EBPOM World Congress, Evidence-Based Preventive Medicine World Congress here in London. And it's great to be here with all these fantastic speakers, isn't it, John?
Indeed. Again, as always, lots of great sessions. Yeah, we just finished one talking about cardiovascular risk evaluation for non-cardiac surgery. So that's been really interesting.
And it's a great pleasure to have both those speakers here with us, joining us on the headsets here on Top Med Talk. I think they've both done Top Med Talk with us before, so very familiar voices. But why don't I hand over to you, let you guys introduce yourself?
I'm Mark Edwards. I'm a consultant anaesthetist and academic based in Southampton, UK. Clinical activity in sort of major non-cardiac surgery and research interests around hemodynamic optimization and emergency surgery, amongst other things.
Yeah, hi, I'm John Whittle. I have been on Top Med Talk before, but I haven't been invited back for a while, guys, just saying. Is there anything I said? I am also a consultant anaesthetist intensivist at University College Hospital, and I also have a academic component to my job, and I run the Peri-operative critical care as well as do non-cardiac surgery, high-risk non-cardiac surgery as my anaesthetic job.
Excellent. And you've both just given some excellent presentations looking at cardiac risk in the non-cardiac surgical patient. I mean, that's a huge topic, isn't it?
It is. It's almost impossible to cover in a half an hour talk. In fact, it is impossible to cover in half an hour talk, especially when my talk was about guidelines that haven't actually been released.
So that is a challenge.
It's challenging, but I think we met it. So I think we...
So just to clarify that for our listeners at home, this is the American guidelines.
American,
soon.
Yeah, it's due out this year. September 2024 is the current slated time for release. So I guess what we did was went back to kind of what are guidelines for, who reads them, how they're used, what we're missing, maybe some of the pitfalls, and some hot topics.
There are some guidelines out there, aren't there? What are the current European guidelines? You were talking about those, were you, Mark?
Yes, I mean, the original intent of the session was going to be a kind of compare and contrast European approach versus American. Obviously, we just had to rejig that around the timing of the American guidance, but it's still been an interesting session. So the European guidelines are from the European Society of Cardiologists, and those came out in 2022. They were an update of their, I think, 2014 guidelines. They've been out there for a couple of years. But, as we made the point in the talks, very much guidelines that are restricted to an interest in risk assessment in terms of risk of cardiovascular complications and morbidity after non-cardiac surgery, and also thinking about how you deal specifically with certain cardiovascular conditions in the perioperative arena for non-cardiac surgery. So, they're big guidelines. They cover a lot of stuff, everything from when to stop antiplatelets and what the indications are and DOACs and so on, through to general minimization of cardiovascular risks and so on. But I mean, I think a really important point that we both made and that the panel made was that, these really do have a cardiovascular lens. There's a very restricted focus to cardiovascular badness after surgery. And I think it's always important to bear in mind the breadth of other post-operative morbidity that probably is more common these days, really. So, it's been a huge research interest, I would say, particularly driven by North American groups, looking at cardiac morbidity post-operatively. Realistically, though, acute MIs, that sort of thing, very well-defined things, and we'll talk about MINs in a moment as a slightly more common phenomenon and what that means. But as compared with, let's say, infections, pulmonary complications, the cardiovascular side of things is less common. So it's an interesting phenomenon. There's been a lot of interest, European guidelines, American guidelines, huge research body focused on complications that probably aren't the most common.
But could be as a result of us having such a focus on them over the decades, or just that they're the ones that kind of get the headlines and therefore that's the attention that we focus on?
They probably were more common in years gone by. I think there's a number of phenomena that had happened. I mean, I think you can argue about what's the driving force for this degree of interest. There's a certain group of perioperative research active cardiologists who have really driven the space forward, which is, it's both a good thing, but it's also, through their sheer productivity, has obviously put a lot of focus on it. And I think, certainly from a European and from a UK perspective, I think we tend to kind of just try and take that in proportion. I mean, other things have probably happened over the years. I think you look outside of the perioperative space, and there's been huge developments in cardiovascular care and probably in cardiovascular health, to be honest. You look at your patients coming through the pre-assessment these days, so many of them are already on their statin, maybe the aspirin for primary or secondary prevention, so beta blocker, that sort of thing. The baseline care and cardiovascular health. And actually, you look at non-surgical literature, cardiovascular morbidity, mortality, has improved year on year. So I think perhaps the relevance isn't quite there as compared with if you went back 30, 40 years.
And what would you say, so from these updated guidelines from 2022, what were your big take-home messages? You mentioned that thankfully most of them are actually fit into that category of kind of common sense or already kind of non-controversial, but a few of the discussion topics that you'd like to highlight?
Yeah, a lot of the content is uncontroversial, strong recommendations, but perhaps on, non-resource intensive practices or interventions, low-risk interventions that you don't necessarily need the nth degree of evidence-based to insist on. So, there's a lot of good stuff in there. There's a lot of very practical, hands-on guidance that you can go to if you're in your pre-assessment clinic to decide, when am I going to stop this drug, or how should I investigate this patient? So there's a lot of really useful stuff in there. The things that really stood out to me, examining them in depth over the last few months, were things that really sort of didn't fit in with practice I see in the UK so much. And it was interesting consulting with the audience, and that, a lot of my sense, it kind of chimed with what the audience were reporting in terms of their own practices within the UK. So things like the threshold for getting a static transthoracic echocardiogram was, fairly low in these guidance. You could qualify to get an echo even if you just had a self-reported poor functional capacity. Now, of course, they're recommending, yes, do them if they've got a new murmur, if you do a BNP and that's high, all those sorts of things, fair dues. But actually, they would also kind of recommend, think about doing an echo just if they're having high-risk surgery and they're reporting poor functional capacity. And I think that's interesting. The guidelines do not really go heavily at all on CPET. And that's obviously interesting for our context. It makes you realise that actually, I think a lot of European practice is to not have CPET within their preoperative workup. Ditto the US practice, from John's experience. It does change your approach to these things because you've got a gold standard test of functional capacity, which also happens to give you information on cardiovascular performance. So that does kind of skew the degree to which you feel you want to get that echo. So I think the interpretation of the echo advice is interesting in the UK, where CPET is much more widespread. The other two areas, and I'll hand over to John to sort of think about these a little bit more, quite widespread recommendations to use biomarkers at baseline and to even track things like high sensitivity troponin throughout the perioperative course. That's interesting. That got the crowd talking because I think that doesn't necessarily chime with current practice, and I think people are struggling a little bit to see how it really fits in and what the role is, even if we recognise that troponin rises after surgery are important. Those were the main ones, really. John, I don't think you sort of speak to the kind of the biomarker piece.
Yeah, well, I'll make a couple of observations, I guess, because of course this conference, I think the predominant attendee is going to be an anaesthetist or anesthesiologist. I would point out that it's not just anaesthetists who read these guidelines. So we're talking pre-assessment nurses, nurse practitioners, physician's assistant. We're talking about the American ones, hospitalists, internists, surgeons sometimes, cardiologists. So one thing we must remember is, there were a few jokes about cardiologists in the session, but, not all cardiologists have a peri-operative hat. But many cardiologists are asked to opine on peri-operative management. And I guess one of the themes that we chatted about was, well, actually, what is the use of these guidelines and what is the use of the cardiology consultation in the peri-operative space? And one of the core consultation uses, which is a use, so even though it is uncommon to have an MI in the post-operative period, so happens, but one of them is, can we prevent it? What do we do about all these advances that have happened in management over the last 15, 20 years? There are a lot of new drugs that we're finding our patients turning up on. There are lots of new different types of stents. Though Mark alluded to it in his talk, how do we manage antiplatelets in that context? So there are some very specific cardiology questions on which there is evidence, and on which we hopefully, with these sorts of guidelines, can gain a sort of consensus between the sometimes conflicting pulls of needing urgent surgery or expedited surgery versus over-under investigating, over-under managing. So I think there's a place, so there are a couple of people in the audience sort of suggested maybe we shouldn't have cardiac or guidelines. I think there's still a place for them, but I guess you just have to try and understand where they're going. The biomarkers question is a really interesting question because there's a resource implication to measuring these biomarkers. Passionate advocates of MINS, myocardial injury after non-cardiac surgery, would strongly advocate for preoperative troponin measurement, longitudinal post-operative troponin measurements in higher risk patients. But, I guess the mood in the room was that that's not happening. And the mood in the room was also maybe that's not a bad thing. And I guess why is a difficult thing. We are interested in perioperative risk. The risk of complications beyond cardiovascular complications, i.e. hypertension, acute heart failure and so on, from a raised troponin is significantly elevated. But is it just a biomarker of systemic physiological derangement, or is it a biomarker of specifically an ischemic issue that requires an ischemic intervention, where that's optimal medical management, whether it's cardiology intervention, etc.? And I think we're a little bit still not there. That's my feeling as to exactly what you do about that.
That was definitely the vibe in the room, wasn't it? That it's not done routinely, but also when it is done,
what does it mean?
What does that exactly mean, and how do we best manage that?
I think just taking a step back briefly, let's just go back to the MINS topic. But for, again, people listening at home, we're banding this term around quite a lot. But what do we mean by MINS, John? What is it, and what are the implications of it for us perioperatively?
So MINS stands for myocardial injury after non-cardiac surgery. It's currently defined as a greater than 99th centile increase in troponin, as in for your lab reference value. The type of troponin, I think broadly, is not specified. That may become important for obvious reasons. And I think the current definitions continue to include MI, whether it's an ST or non-ST elevation, because that is a type of myocardial injury. However, that clearly has a slightly separate and definitely cardiac management implications. I guess MINS as well, in terms of troponin rise, the degree of troponin rise has prognostic implications. So, if your reference lab upper limit is 14, a troponin of 15 on day 1 to 3, it's normally within 48 hours of surgery, abdominal surgery being the most common in the literature, has a lower risk of complications as compared with a higher, like a 90th centile rise. So there's, even within MINS, there's different degrees of myocardial injury. And I guess the lens with which we look at it is really the key here. And I think it's important probably to look at it with both lenses. And the reason I say that is because across my bias is that across the medical world, if you hear cardiac troponin, not unreasonably would you say that is due to myocardial or heart muscle injury. Heart muscle has died, troponin has gone up. Most common, or in our lens, as historical lens, reason for that has been because there's been ischemia. So I guess one component is has there been ischemia? What type of ischemia? And we could talk about that more. But of course, the other side is there are, and we are all aware of this because I think anyone that works in perioperative medicine will have come across patients who have an elevated troponin in the absence of any other sign of myocardial ischemia. Patients with renal disease, some patients with diabetes, heart failure, they will present with elevated troponin in their blood, and they are not necessarily actively ischemic. So I guess, as a biomarker of systemic physiological badness in the absence of other biomarkers that could tell you the same. Because when we talk about complications, which Mark was saying, the 16% risk of complications post-operatively, we're talking about complications across multiple and sometimes concurrent organ systems: kidney failure, delirium, pneumonias, infection, and an elevated troponin does predict those as well. So that's where this debate, this difficulty comes in, because how do you separate out, the ischemic component? And as Mark alluded to, there's been a bunch of attempts to mitigate or reduce cardiac risk using pharmacological interventions, beta blockers, clonidine being obvious examples. And on a sort of global basis, they haven't been as successful as we'd have hoped. So, this MINS debate is going to rage for a while. Another brief observation about troponin is that the assay of troponin is important, because most assays are looking for a segment of troponin, a component of cardiac muscle cells, that may be a fragment. And there is a lot of literature out there about how troponin may be released from not dead or dying heart muscle cells in the context of various immune inflammatory situations associated with and not associated with ischemia. And this is kind of, I think, where the murkiness comes in.
Mark, going back to the biomarker question briefly, so obviously troponin we talked a lot about with the MINS story, and the MINS debate is quite a nice way of putting it. But you, I think, mentioned some other biomarkers in the session as well, which have potential uses in this space.
Yeah, so the other main one is obviously the natriuretic peptides, so BNP or NT-proBNP. The SC guidelines recommend taking the BNP from the pre-assessment clinic if there's any dyspnea or any peripheral edema that's not got a definite other cause. So if you've got unknown breathlessness, they suggest a BNP, which I think is, that's a very reasonable idea. Heart failure is going to be on the list of differentials, so BNP is a good good idea in that space. What I would say is that in the sort of global recommendations for the extent of workup for patients, again, the bar is quite low to get into preoperative biomarkers, specifically BNP, troponins. It could just be patients who are over 65 having moderate to major non-cardiac surgery. So most intracavity stuff in, frankly, most of the patients I see would end up being recommended biomarker checks at baseline by the European guidelines. BNP, in a similar fashion to the troponins, has got prognostic power. So we know it can predict post-operative cardiac and some other complications as well. So we know it's important. Again, it's a case of, have we got the machinery in place to deal with that? How are we going to use it? There was an informal straw poll in the room asking people how they felt about, for example, almost using it as an echocardiogram avoidance technique. So as a rule out. So you've got a slightly breathless patient or one with poor functional capacity that for whatever reason has not had a CPET. And again, even in the UK, that could relate to patients who aren't able to CPET. Low limb arthroplasty patients, for example, who might struggle. If there's poor exercise capacity, you could say, well, I could do a resting transthoracic, but actually, why don't we do a BNP? The BNP is low. You're pretty unlikely to see significant LV dysfunction on that echo. So, assuming there's no murmurs, let's just proceed based on that. So some prognostic ability, some diagnostic stuff. Again, straw poll in the room seemed to be that actually quite a good number of people there from across the territories they've come from have asked for BNPs in their recent practice. Our hospital's interesting because a raised BNP actually automatically generates a referral to we've got a BNP cardiology clinic.
Right.
And a colleague once recently had a phone call from our cardiology friend saying, what's going on? You sent off this BNP and now I've got a patient to see in clinic. What's this all about? But again, they got worked up. They got the right sort of workup to get them into surgery. So, yeah, I think that, there's an interesting place for the BNPs. Again, it's possibly a bit less controversial than the troponins. I think the thing around the troponins is I think most of us would appreciate, yeah, it's definitely a thing. It's important. It's prognostically important. This is not to put that to one side or to ignore the whole phenomenon and its importance, but I think John and I both feel we really need, there's a lot of work to do in understanding exactly what is driving this, because, there will be almost certainly various overlapping phenomena that would lead to a raised troponin, and you need to be treating the right thing.
Yeah.
Well, I don't know if you want to talk to PJ Devereaux's RCT with NOACs versus control for those with raised troponins.
Well, yeah, so this is why it's complicated, isn't it? So in fact, there's 2 studies. So there's dabigatran given to patients with elevated post-operative troponin, better outcomes, and referral and or transfer to cardiology care in patients who satisfy the criteria for MINS appear to have better outcomes. Now, I guess it still doesn't answer the question. I mean,
or were the outcomes, they were just
30-day mortality,
right,
and I think it was 30-day mortality.
That was the main one.
Yeah, the main primary. I guess the other thing with all these guidelines and the work, you alluded to it in your talk, Mark, is that, in reality, anyone that works in the perioperative medicine space and sees, free-range patients turning up with a surgical problem, there are a lot of patients out there who have not seen a GP or a family doctor for quite a prolonged period. And I guess what is interesting in this is the potential tension, again, between our biases. So I think Mark and I both practice normally high-risk, major, complex, non-cardiac surgery, often in cancer patients where there's a time limit in general on time from assessment to operation for good reasons. And in those situations, actually, what we're interested in is there anything that we need to do
differently
now? Yeah.
Yeah.
And the general vibe, I think, of the guidance is, well, actually, only if you would have done it anyway for ischemic heart disease, whether that's stenting or an investigation or like a stress test or something like that. But then I guess you've also got and this is not explored, but it's important to talk about, just like there's massive waiting lists to see a cardiologist, there's massive waiting lists in the UK to have your hip done, to have your knee done. And actually, if you are turning up on a list with a bunch of cardiovascular risk factors where, in fact, it doesn't have to be a cardiologist who's optimizing these things. There's a lot of good guidance out there in the general practice world about optimizing. I think, number one, it's not massively well covered by these guidelines, but number two, it is extremely common. And there's a tension between what we want to know in terms of perioperative risk and what risks we're thinking about, and maybe the secondary intent of perioperative medicine, which is, an epidemiological improvement in outcome longer term, even despite the index surgery. So, it's hard. These guidelines are hard, and the purpose of them difficult, because you could encompass so much in them and lose the message.
I guess one thing we haven't touched on yet, but as well as the biomarker story and when or when not to get a transthoracic echocardiogram, what about functional assessment and that sort of role in all of this?
Right. Yeah. And so we touched on that in the session. And this again comes down to implementation. I think Lee Fleischer mentioned this as a member of the panel. You can make a recommendation, and Mark has we just talked about it with troponins, but how do you implement it? So I guess you've got to start with a few ground truths and just say, well, we definitely know that reduced functional capacity is associated with adverse outcomes after surgery, including adverse cardiac outcomes. We know there are a bunch of ways of assessing functional capacity, from questionnaire, DASI is the common one that we talk about, Duke Activity Status Index, to asking the patient. Not necessarily a reliable tool, and that was actually quite clearly brought out in a variety of studies. Asking the physician what they think the patient's good at, METS quite clearly showed that, amongst others, that we're not great at judging our functional capacity. Measuring it by asking the patient to climb some stairs with you or not. 6-minute walk tests, 6-minute step tests, sit to stands, CPET, which of course are highly available in both of Mark and my centres, and I am an enthusiast for it. But what is reasonable, and what outcome are you trying to get out of it? And so with a functional assessment, this comes down to any risk assessment, I think, even in the troponin debate. What is the outcome? So if you are just looking to predict a risk, or a risk of any outcome, then your way of doing that should probably be the least burdensome that you can, which is why I'm not against using DASI to help predict cardiac risk, because at the moment it does. You can debate away why or why not and so on, but it does. And it might not be reasonable to ask a hospital to spend £40,000 on a exercise bike setup and then pay an exercise physiologist, plus or minus someone to interpret it, and then do the whole implementation of how do you use those data, etc., etc. So I guess you've got to have a stepwise approach to assessment. You've just got to know what you're thinking you're going to do with it. So with a CPET, the reason that Mark and I like it is because we can get other data out of it. So, I can tell you anecdotally in the last year, we've diagnosed PEs, we've diagnosed pulmonary hypertension, we have identified coronary ischemia, we've identified significant heart failure, we've found people with valve issues. But that's because it is totally embedded in our workflow. And we've also been able to give some information on risk, and we've also been able to give some information on how to optimize that. But if I'm doing a large volume clinic, I'm not going to CPET everyone. So what's the next best? And I guess that's where this functional assessment, what are you going to use? My bias is still use a tool that actually assesses the functional capacity of the patient, whether that is sit to stands or climbing stairs with the patient or whatever, because you could put a number to it and you can understand how in your institution that relates to the risk.
A subjective assessment, not a subjective interpretation.
Exactly.
Yeah. The other thing, obviously, with CPET is in centres where prehabilitation has been taken on, CPET can be really important for dosing that exercise, can't it? That's another reason why it's being done fairly routinely in a lot of our patients. But I think within the ESC guidelines, CPET is very much put to the side based, I think, most strongly on the results of the METS study. As we know, it was not found to be particularly predictive of the primary outcome, which was, a very cardiovascular primary outcome. But interestingly, that outcome happened less frequently than all other non-cardiac complications, which happened in 15 or 16% of patients. Interestingly, CPET did have predicted value for those other complications.
So it was the only marker in that study that predicted all the other complications.
So it's not the headline of the study. It's not the key thing in the abstract, but actually when you go into it, clearly it's still got prognostic ability across a wide range of slightly more common outcomes.
And I suppose though the guidelines are the difficulty with guidelines is that you're trying to develop something that is amenable to a very wide audience.
Yes, indeed.
And I suppose they're thinking, well, CPET isn't in every single hospital institution.
Absolutely. I mean, you could argue me and John work in slightly unusual centres, but actually the show of hands in the room would suggest that many centres around the UK have got some access at least to CPET. So I think there's geographical variation. And the other thing is, this is definitely not to point criticism at the guideline makers. They had their scope of practice. They had their remit for the guidelines, which was very specifically to restrict themselves to cardiovascular risk prediction. Now, you can say whether that's a helpful thing in general terms or not, but actually, if you're doing your job and you're literally focusing on that, you can look at METs and say, well, actually, that particular test was not so good. So I'd advise anyone who's looking at these guidelines to say, there's justifiable evidence quoted in relevant questions. You just have to be aware of the world around it, of non-cardiovascular morbidity and the fact that other risk tools might therefore come into play or be in your practice already, and that's okay. So it's a case of, how do I make that work in my practice? I might not order that many echoes because I've got functional data from a CPET or, cardiac function data from the CPET, which is reassuring, even if, I was concerned about reported functional capacity before that. And the ESC guideline, therefore, falls down much more on either using the DASI or just using patient-reported ability to climb 2 flights of stairs. And again, I think a lot of anaesthetists would look at think, I'm not sure if that slightly subjective reported thing is something I feel comfortable potentially pushing patients down the route of stress testing, echoes, that sort of thing. And they may sort of hesitate to put too much weight on that. So I think that's going to be a challenge in terms of implementing that bit of the guideline and embedding it into routine practice.
And I guess as well as embedding all this into routine practice, it's clearly an evolving field, and you've both highlighted a number of studies already whilst I've been talking that have come out and changed the direction of things even quite recently. I guess that's continuing all of the time. And the European guidelines, as we said, are 2022, so already a couple of years old. The new guidelines we're expecting to come out hopefully later this year, the American guidelines. And again, I know we can't predict the future, but any thoughts, both of you, on any changes or any differences or things that might be in those guidelines we should be looking out for?
Yeah, I mean, I guess if you were writing these guidelines back to would you include CPET? Probably would, if you were talking about functional assessment as the gold standard. As I alluded to, you might not suggest that that's a recommended thing in the context where people don't have perioperative CPET. I guess the MINS literature, the anticoagulation, so the around stent literature has evolved in that period. There will be, particularly MINS, I suggest, there was a recent AHA-ACC guideline about management of MINS that came out last year, I think. So that will totally influence, because that's how those guidelines work. They unless there's novel evidence, they would incorporate and use the same guidance.
I guess other thoughts which might not make it into the current guidelines that are expected just because of just how long it takes to finalise guides, get them reviewed, peer reviewed and so on. I'm thinking POISE 3 may or may not have had a chance to get out into the latest ones. Certainly in the 2022 European guidance, tranexamic acid is recommended for those where there is established bleeding. And I think that piece will almost inevitably get modified by POISE 3 for the next iteration, just in terms of being a bit more, having a wider range of indications, probably being used, not routinely, but certainly more widely. Obviously, there's the second factorial part of POISE 3, which is interesting around hypertension avoidance, hypotension avoidance. It'd be interesting to see how guideline committees interpret that. The other thing which I didn't really touch on in the talk is around intraoperative hemodynamic management. They recommend goal-directed therapy as a means, intraoperative goal-directed therapy as a means of reducing postoperative cardiovascular morbidity. It's possible that piece again might change in the fairly near future. Results of OPTIMISE II, we hope, going to be out and published soon, and ditto Flow-Ella in the coming years. Similar thing in emergency surgery. So I think the approach to goal-directed therapy in terms of relevance for post-operative cardiovascular stuff might change as well. And there was one other thing that has slightly slipped my mind.
It's probably some drugs as well. So more drugs that are more commonly prescribed even for non-cardiac reasons, like sodium glucose-like transporter inhibitors, the flozins, the weight loss drugs.
Yeah.
And also, I guess, the management, the management of conditions that do increase your cardiac specific risk for a cardiac guideline, such as diabetes, may be of interest in a cardiac guideline. But then you really strongly then have this sort of where does it end, back to Denny's previous thing of, should you really have organ system specific guidelines?
I've just remembered the other one, which was around ACE inhibitor, ARB, stop, don't stop. And obviously the space trial is now out, isn't it?
Yeah, absolutely.
Which seems to turn things on its head a little bit.
That is huge. It turns things on its head, doesn't it? But yeah, that's a really interesting topic. And I guess over the years, if we were forecasting, maybe not for this year's set of guidelines, but the future, we've kind of alluded to this. Actually what we're talking about is complex phenotypes, complex interactions between multiple medical conditions, biomarkers, risk assessments, etc., etc. I suspect there will be more and more machine learning based models of risk. I mean, you just have to look at the NSQIP risk calculator at the moment, which already incorporates machine learning and has different models for different outcomes. And I suspect that will be making more waves in cardiac as well as other guidelines going forward.
I think sadly we're probably running out of time, but very quickly before we finish, do you want to give us a quick elevator summary of that space trial for people that haven't had a chance to read it at home yet?
No.
In fact,
in 10 seconds.
Yeah. So the bottom line is, it may be, I can't off the top of my head, but
if you want to
cut it out. Yeah, but I mean, the bottom line is you may do better not stopping.
Not stopping.
Yeah.
Fine. Yes, fine. We'll get that bit out. That's fine. Brilliant. Well, thank you both for your time. Great session. Really interesting follow-up from the audience as well in the room. Thank you for joining us here on Top Med Talk. As always, you can hear this conversation and all our other conversations on our website, through our app, or on any podcast channel of your choice. Please do find us on your social media channels as well, on Facebook, on X, or formerly Twitter, and on LinkedIn. And if you see us on YouTube now, make sure you give us a like and subscribe on there too. And thanks again for joining the conversation. Thank you both for joining.
Thank you. Thank you.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.